Good evening, everyone. So I'm Dr. Bhavya Reddy, and I have recently in 2020 I've given my step 2, and in 2022 in 2020 I've given my step 1, and in 2022 I have given step 2. As a recent exam giver in both NEET PG and USMLE, I understand the kind of process that is required for us to go through these so-called dreaded exams. So let's begin this journey together, and hopefully we'll have a better understanding as to how we can prepare for this big so-called USMLEs, and let's try to make the process easier and in a much more digestible way, right? So about the USMLE exams, I'm sure everybody is aware that step 1 has recently been converted to a pass or fail exam, but that doesn't mean you take the exam lightly, because step 2 is essentially 60 to 70% of step 1. So if you're good at your basics in step 1, then half of the job of step 2 is done. So ideally, we want to be focusing more on our basics and how do we integrate them in approaching the questions. USMLE is not just about knowing the knowledge, but it's also about applying the knowledge So we'll be giving step 1 and then step 2 CK. Right now, step 2 C has it's been put on a hold. So you give the pathways and then you get ECFMG certified and then you apply for step 3. So ideally, that's the brief outline. So we'll start with a very simple topic, very approachable topic. It's not really complicated, but then just a tit and bit here and there and your approach completely changes, right? So first, what is anemia? If I speak physiologically, anemia is blood's capacity in decreasing capacity of carrying oxygen, right? So WHO classifies anemia. If you are a male, if your HB is less than 13.5, then you're anemic, according to WHO classification. If you're female, if your hemoglobin is less than 12, then we call the female to be anemic. So, USMLE is all about questions. So I've already highlighted a part for you. Let's just go through the question stem once. It's a 20-year-old female who is coming to you with complaints of heavy menses. So I'll just highlight history of heavy menses, right? And she's presenting to you with fatigue. Then she also states that she barely has energy to do less than 80, right? Normal mean corpuscular volume. When I'll be showing, and normocytic will be 80 to 100 and macrocytic will be 100. Okay, can be. I look for my MCV values. So by looking at my MCV values, I can actually rule in, is it IDA or is it folate deficiency or is it B12 deficiency? So that is how we'll be approaching anemias, right? I'll just scroll through. Now, as someone had said, okay, I've gotten a microcytic picture. Now that I've gotten a microcytic picture, see, clinically what microcytic picture. Now that I've gotten a microcytic picture, see, clinically what we do is, if you have a microcytic picture, you'll start the patient on iron supplementation and you'll ask them to come again after 3 weeks, right? And you'll again check if there's an improvement or not. Usually, if there is an improvement, it's iron deficiency anemia, and we'll just treat it as an iron deficiency anemia. When there's no improvement in the patient's hemoglobin, then we want to go for further workup. What is the further workup we do is something called as iron studies, right? So let's just try and make it interactive. I'm sure everybody has gone through these things once or twice, maybe in your first prof, second prof, or final prof, right? So now I've got microcytic picture and I have done my iron studies. So the first thing, let's just go through the first thing. They're saying that serum iron is decreased, okay? And transferrin. So what is transferrin? Transferrin is a carrier molecule of iron. Transferrin, the carrier molecule of iron, has increased, which means what? That iron saturation has decreased, right? Ferritin. What is smear? If we see this in the iron studies, what is the diagnosis you want to give? So, right, someone, Rachna has mentioned, it is iron deficiency anemia, right? So, just look at the peripheral smear here. And can anyone tell me what are we looking at the peripheral smear? What are we looking here? What exactly is this peripheral smear trying to show us? I told, right? We'll see how you actually pick up microcytic on a peripheral smear. So see, usually when the RBC is there, only the center 1/3 should be pale, whereas the rest should be dark in color compared to the center. Now, if you look at this, all these cells, the center paler is greater than 1/3, right? So this is how we say that this is a microcytic anemia, okay? Right. So next coming to the second differential that I want to consider, okay? See, like the earlier case, serum iron has been decreased, but right
Excuse
now,
me, doctor.
ferritin. What is ferritin? Yes, yes, Rakshit.
The MCV should be less than 100, right, for the microcytic anemia?
No, MCV should be less than 80 for microcytic anemia, 80 to 100 for normocytic anemia, and greater than 100 for macrocytic anemia. Okay, am I clear?
Okay, doctor.
Okay, thank you, thank you. So we're going. Yeah, iron deficiency anemia is a example of microcytic anemia. Under microcytic anemia, this is we have to consider thalassemia, iron deficiency anemia, sideroblastic anemia, and anemia of chronic disease. Right? Yeah, even if you're a first year, anemia is something you come across in physiology. It may not be discussed in this depth, but I'm sure you'll have an edge over your batchmates if you go through this, right? So now let's just look at another similar scenario where iron is decreased, but ferritin levels, which is what the storage form of ferritin, is increased, right? So if my serum iron is decreased and ferritin is increased, what is the thing that I'm considering, right? What are the thing? What do you want to look at? What is your differential when serum iron is decreased and ferritin values are increased? Right, as Rachna is telling, yes. Um, so someone is asking constantly regarding transferrin saturation, right? So what exactly is transferrin saturation? Transferrin saturation is nothing but serum iron divided by, I'll just write it down here. I'm writing it here. Serum iron divided by total iron binding capacity. Okay. So we look in anemia, we look at iron deficiency anemia only. So what is happening in serum iron in anemia? It is decreasing. What is happening to total iron binding capacity? Because there's no iron bound to the transporter, the total iron binding capacity is increasing. So the numerator is decreasing, the denominator is increasing. What will happen to the percentage transferrin saturation? It will be decreased, right? I hope I'm clear. Whoever asked about the transferrin saturation, okay? Cool. Thank you. So moving on to the next one, where we're thinking about serum iron is decreased, but the ferritin values are increased. This is nothing but anemia of chronic disease. So what do you think in anemia of chronic disease is basically that there is chronic inflammation which is going on. And I'm sure that everyone is aware that ferritin is actually an inflammatory marker. So because of this, there is more iron storage in the reserves, but the iron in the serum is decreased. Okay. That is how we pick up iron of anemia of chronic disease. Okay. So the next thing I want to see is serum iron is increased. Okay. And ferritin is also increased. Serum iron is increased. Ferritin is increased. And this is what I see in my peripheral smear. Can anyone pick up what cells I'm trying to show in the peripheral smear? This is a slide from the peripheral smear, and this is from bone marrow. So can anyone tell me what are the specific cells that I'm trying to? Is it the problem with everyone? Or is my internet not good?
It is good.
Okay, good. Thank you. Okay. So yeah, so we were discussing that serum iron is increased and even my ferritin levels have increased, and in my peripheral smear, this is what I'm seeing. So can anyone take a guess? What are the cells that I'm trying to show here? What is this thing? What are these dot things that I'm seeing here? Anyone? This is what we call as basophilic stippling. Okay, right. So as Roshan has correctly said, this is what we're called as basophilic stippling. Okay, and this is something we see on bone marrow. I'll give another clue. This is a Persian blue stained slide. Anyone wants to go for this? This is a Persian blue stained slide on bone marrow. What are we calling this? This is nothing but sideroblasts, right? This is all the iron that has got deposited in the bone marrow, right? You can see iron doesn't take the normal Romanowski stains that we use for bone marrow slide preparation. So we specifically give a Persian blue slide. So in the exam, if you have a Persian blue slide, you can just think blindly that it is an iron stained macrophage and just mark your answer as sideroblastic anemia, right? So if anyone is feeling kind of overwhelmed, then this is just an introductory class with an overview. So this is just to give you an introduction on how we're going to discuss. So just don't get overwhelmed by thinking, yes, kya ho raha hai? What is all this happening around, right? And if another thing, which is a microcytic anemia, and iron levels can be anything, but this is the classic peripheral smear that you see. Can anyone pick up this? What are the cells? What are these cells that I'm trying to show on peripheral smear? Anyone?
Target cells.
Right. Perfect. Excellent. So these are your target cells, right? So when I have a microcytic anemia with target cells in my peripheral smear, I am going to think of thalassemia. Okay. So let's just look at the peripheral smear slides, and we can just first of all, if it's a microcytic anemia, I'll blindly consider it as an iron deficiency anemia and start my iron supplementation. Yeah, right. So someone has said hemophilia. What is the thing that we expect in hemophilia? Do we expect any abnormalities on peripheral smear in a hemophilia? Right. So none. And hemophilia is an example of a coagulation disorder where your coagulating factors are abnormal, right? We don't expect any abnormality in the RBCs or the peripheral smear. Okay. So these are just a couple of peripheral smears that everyone should be. Can megaloblastic hyperchromic anemia occur? So see, megaloblastic hyperchromic occur. Megaloblastic is different. I'll tell you what exactly is megaloblastic and what is macrocytic, what is hyperchromic. All these are completely different terms, and we should not confuse one with another. Okay. So now, this is another question. So we finished our discussion on microcytic anemias. Now we're approaching towards megaloblastic anemias. Okay. So let's just go through the question together. It's a 9-month-old female. So it's a relatively younger child, right? She's presenting to you with failure to thrive. There is developmental delay, and she's also having an anemia with the peripheral smear. Anyone wants to take a guess at what is the peripheral smear trying to show? You can just type in the chat box. What is this peripheral smear trying to show? Anybody? Someone asked, right?
Megaloblastic anemia due to
Yeah, but why exactly it is a megaloblastic anemia? Why exactly?
It is giant neutrophil, I can see.
Yeah. So what exactly are those called? Anybody?
Giant neutrophils.
So what is a megaloblast? We're saying megaloblastic anemia, and
like lacking vitamin B12, vitamin
Vitamin
B9.
B12 deficiency.
Yeah, that is exactly. See, our right. Right. So let me just explain. So in a normal neutrophil, okay, we have 5 or less than 5 lobes. Okay, so I'll just count how many number of lobes are there. I can say 1, 2, 3, 4, 5, 6. So there are, right, these are cells called hypersegmented neutrophils, right? Right. So whenever we expect, I really like how everybody's thinking it is B12 and okay, let's just go A, B, C, D. What do you guys think? Just type in the chat box and let's see, A, B, C, D.
Serum cobalamin levels, B.
Okay, somebody wants to do both B9 and B12. Somebody wants to do, right, Roshan. I see a very good answer, which is orotic acid crystals, right? So actually that is the right answer, and I'll tell you why also. So the reason I've asked this question is, right, so the reason I've asked this question is because whenever we think of megaloblastic anemia, everybody thinks it's either B12 or it is folate deficiency. But there's another entity as well, which is that is called as orotic aciduria. That also can present as a megaloblastic anemia. So this is where your question stem becomes important, right? You don't just see your peripheral smear and mark the answer. You look at it. It's a very young child. When do you expect B12 deficiency? When do you expect folate deficiency? And also B12 deficiency, usually vitamin B12 has very good liver stores. So for a vitamin B12 deficiency to occur, you should at least have deficiency for 5-6 years. Only then B12 deficiency occurs. Right? So right there itself, I can say it's not B12 deficiency because the child is only 9 months old, right? And also the presentation, look at it. It's failure to thrive, developmental delay, and the blood tests are showing normal ammonia levels. What is suggesting here that it is folate deficiency or B12 deficiency? Do we have, sometimes it is about ruling out. There are no risk factors for folate deficiency, no risk factors for cobalamin deficiency. Only when I'm thinking about these two, I'll consider homocysteine and methylmalonic acids, right? So you can just rule out, even if you don't know the fourth answer, you can rule out. It's not the other three, so it might be the fourth. I'm sure that is how. Exactly. So that's how Roshan has picked up, right? Sometimes you're not smart enough to know all the answers in the question. So you can rule out what you know. Okay. So I'll just very briefly tell you how do we approach a megaloblastic anemia, right? So usually I'll just pick up what the question which was about, right? So what people tend to forget is something called as orotic aciduria. Orotic aciduria. Excellent, excellent. That is the kind of approach you need for USMLE. It's not just thinking that why this is the right answer. You also need to know why the others are the wrong answers, right? So we'll think about first. Let's just go through orotic aciduria, where you have a defect in UMP synthase, and because of the UMP synthase, there is an inability to convert orotic acid to uridine monophosphate. Okay. So usually what will these children present to you with? They'll present to you with anemia, failure to thrive, and developmental delay, because this is a enzyme deficiency which is being involved in the purine and pyrimidine pathway. It will present early. Okay. So there is another thing where you can have orotic acid increase. Anybody? I mean, the answer is already here, right? So if your question stem says that I have done my blood analysis and there's an increased orotic acid, right. It is pyrimidine synthesis, right? It is pyrimidine degradation, right. So we are thinking about increasing in orotic acid, right? If there is an increase in orotic acid, you should also check if there's an increase in orotic acid and if there is an increase in ammonia or not. If there is no increase in ammonia, then it is because of a defect in UMP synthase. There is a defect, if there's an increase in anemia as well, then you're thinking about ornithine transcarbamylase deficiency. Right? That is a discussion for another day. I'm sure we'll pick this up again in biochemistry. But I just want you to know that when you're considering megaloblastic anemia, please keep orotic aciduria as a differential at the back of your head. Okay, that's the takeaway message. We'll discuss these again in detail. Right? So next, coming to folate deficiency and vitamin B12 deficiency. I mean, this is bread and butter for all medical students, right? So if I just want to highlight one thing which can be asked in a trickier way is that hemolytic anemia also can cause folate deficiency. Anybody quick guess why hemolytic anemia will cause folate deficiency? Right. So why? My question is why hemolytic anemia will cause folate deficiency? Anybody? Just use your brain. Very good, Ali Hassan. Right. So there is hemolysis of the anemia. If there's hemolysis of the RBC. So if there's a hemolysis in the RBC, there's also an increased production, right? And for increased production, you require more folate and more B12. So, we'll come to the hemolytic anemias next, but classically it will be a hemolytic picture where they give you a high retic count, where you'll see schistocytes in your, in the peripheral smear, and then there will be no hemolytic diagnosis, but they'll give you vitamin folate deficiency. This is just a tricky way where they can confuse you. So just keep it at the back of your mind that even in hemolytic anemia, we can expect folate deficiency, right? And another important difference between folate deficiency and vitamin B12 deficiency is that in folate deficiency, there will be no neurological symptoms, whereas in B12 deficiency, there will be neurological symptoms, right? This is what we call as subacute combined degeneration. Can anyone quickly tell me what are the pathways that are involved in subacute combined degeneration? Anybody? Okay, so there are spinocerebellar, corticospinal, and dorsocolumn pathways. These are the pathways that will be involved in subacute combined degeneration. You can just simply remember from SCD. That itself gives you what are the pathways involved in B12 deficiency. So how do I differentiate between folate and B12? Obviously, you look at the risk factors, what is causing it, and then you look at the clinical features. Are there any neurological symptoms or there are no neurological symptoms? And then you'll order your labs. Right, and in folate deficiency, you'll have an increased homocysteine, but you'll have a normal methylmalonic acid. Whereas B12, you'll have both increase in homocysteine as well as methylmalonic acid. Why? Why do we see an increase in methylmalonic acid in B12? Anybody? Okay, I'll just go through it quickly. That when we have fatty acid synthesis, in that there is a pathway where B12 will be required. If there's no B12 requirement, if there's no B12 as a cofactor for that, then methylmalonic acid will be done, right? So these three have an overlink with biochemistry, and trust me, how we're integrating biochemistry and pathology here. We'll try. Right. Excellent. So this is just an introductory class. So I have not really bought in the pathways here. But this is essentially how we'll be studying, right? Integrating pathology, putting peripheral smears, and then also correlating them with your biochemistry cycles to see how exactly the pathogenesis is. So now we understand, right? Megaloblastic is nothing but all about biochem, and you need to have your cycles perfectly done for megaloblastic anemias. So done. So we have come, let's just go back and look at this table. So we have discussed about microcytic and macrocytic anemia, specifically megaloblastic. So in macrocytic, let these cycles. It's okay. Don't worry. This. So you don't need to know all the cycles in biochemistry. It is really important to understand the cycles rather than memorize. ये enzyme यहाँ पे आता है, या this is what. You don't need to remember all that. You need to know the clinical significance of those pathways, and I'm sure we'll be with you, and we'll tell you why, what, and everything. Biochemistry is not as dreaded as it sounds, right? We'll get through it. No worry. So now very quickly we'll go through normocytic. I mean, the session is getting lengthy. So when we have a normocytic anemia, we'll look at non-hemolytic and hemolytic, right? So what is non-hemolytic? How will you find out is there's something called as retic count, okay? Retic count will give you, if there is greater than 3, we call it as an increased retic count, and it is an indicator of hemolysis. So when we have a high retic count, we call it as a hemolytic anemia, and when there's a non-hemolytic, low retic count, we call it as a non-hemolytic anemia. So we can have it in early iron deficiency, anemia of chronic disease, aplastic anemia, and chronic kidney disease. So what everybody loves is hemolytic anemia. Hemolytic anemia further can be intrinsic as well as extrinsic. Intrinsic will be membrane defects, which is hereditary spherocytosis and paroxysmal nocturnal hemoglobinuria. We can have enzyme deficiencies, G6PD and pyruvate kinase, and hemoglobinopathies, which everyone I'm sure knows, sickle cell and HPC. If they are intrinsic, autoimmune, microangiopathic, macroangiopathic, and infections. So this is the slide which pretty much sums up hemolytic anemia. If you want to know, this is the slide you need to know. And when you're reading, also try to put everything together so that it's all together at one place. Okay. So now I have hemolytic anemia. So what are the RBC breakdown products, right? So RBC will release LDH. So you're going to have an increased serum LDH, and RBC is nothing but heme. Heme will have bile and everything. So we'll have jaundice as well. So classically, it will be a child or an elderly patient who will tell you, I'm not able to do my daily activities. I'm suddenly noticing that yellowish discoloration, extrinsic causes of hemolytic anemia, right? So intrinsic causes, extrinsic causes. Intrinsic matlab something which is related to the RBC. Extrinsic matlab it's not, something is being produced against the RBC, so the extrinsic. AIHA stands for autoimmune hemolytic anemia. Microangiopathic, macroangiopathic. Microangiopathic matlab whatever is happening in the smaller blood vessels of your body. DIC, TTP, HUS, okay, if I have to elaborate, DIC is disseminated intravascular coagulation, TTP is thrombotic thrombocytopenic purpura, HUS is hemolytic uremic syndrome, SLE I'm sure everyone knows, and HELP also I'm sure everyone knows, right? So macroangiopathic is when you have aortic stenosis, prosthetic heart valve. Can anyone guess why macroangiopathic will cause anemia? Any guesses? Why macroangiopathic? Like if you have an aortic stenosis or there's a prosthetic heart valve, why do you think you have a hemolytic anemia? Anyone wants to take a guess? Just basic physics, we've all learned it in 11th and 12th or whatever. Just go for it. So basically, when you have aortic stenosis or a heart valve, you're creating a high pressure, flow there. And when we have high pressure flow, you'll have an increased turbulence. And because of an increased turbulence, there is a high risk that the RBCs could lyse. So that is why we can expect a hemolytic anemia, right? And I'm sure infections everybody knows. Malaria and babesiosis will also give you hemolysis, right? So now coming to hemolytic. So how do clinically, usually they'll give you anemia, clinical features of anemia and clinical features of jaundice will be there. Sorry, turbulence will cause RBC breakdown. Yes. So turbulence in the sense the valves which will be there, they will, the RBC, normally you should have a streamline flow which will be there with your normal valves. And when we have usually prosthetic heart valves, which were actually the older 20, 30 days back wale valves, they used to carry high resistance flow. And because when the RBCs were passing through these valves, there was a risk that, these RBCs could collide with those walls and they could break down. So that is what I meant. That is the explanation. Same thing for aortic stenosis, right? So that is the explanation for macroangiopathic anemia. Okay, so this is a class on anemias. trust me, we'll be with you for biochem and we will make it as interesting as this is, right? Don't worry. Just don't worry about, biochem, how we learn all this. It's about learning what is required and leaving the rest, and also clinical significance of each thing. Don't worry, Roshan. We'll do it. Okay? Don't worry. So now hemolysis. So my hemolysis can happen in the blood vessel where the blood will flow, or it can happen extravascularly. So why will lysis happen extravascularly? It can happen in the liver as well as in the spleen. Right? There's a concept called as reticular endothelial system where RBCs can get broken down. So we're thinking about intravascular or extravascular. Okay? So agar intravascular hai, what are the reasons? It is PNH, microangiopathic and macroangiopathic. If it is extravascular, where you classically see splenomegaly, you have hereditary spherocytosis, sickle cell, autoimmune and pyruvate kinase, right? So let's just go through this peripheral smear, let's just try and identify what is this. Can anybody, probably from second prof or final prof, pick up what is this that I'm trying to show on peripheral smear? Anybody? Any guesses? Okay, let me give you some clinical clue. Okay? So this is classically a 18-year-old African American male who has told me he has started having sulfa beans. Okay, history of
sickle cell anemia.
No, but okay, you're trying. I appreciate that. So there is sulfa beans. Achha, I'll give you one more clue. Right, excellent. Roshan knows everything, right? So, or else in our, right, perfect. So, sulfa beans. Or in India, classically, they'll say that they have been treated for malaria, right? So, whenever.
Glucose 6 phosphate deficiency.
Perfect, Zachary. Perfect. So, these are, as somebody has mentioned, these are bite cells. So, what happens is because of the oxidant stress, okay? Because of the oxidant stress, your hemoglobin will form a clump in the RBC. And when these RBCs, right, cool, great. Okay, so because when these clumped RBCs are going through the spleen will eat it off, and that bitten part is this, and this is what we call as bite cells. And this is what is characteristic of G6PD. Amazing. You're able to pick up cells on peripheral smear, then you got it. You know your anemias pretty well, right? And always use your clinical findings as a clue, because we've already seen, right? Just hypersegmented neutrophils doesn't mean B12 and folate deficiency, right? Yeah, we'll come to Howell Jolly bodies also, right? I'll pick it up at the end. Perfect. So can anyone tell me what is these? What are these?
Sickle cell anemia.
Right. Okay. Why? Okay. It's actually not correct. I'll show you sickle cells as well. I'll give you a hint for this also. IDA. Why IDA? See, this is again exactly why. Peripheral smear. Explain again the bite cell case. Okay.
Is this helmet cell?
No. Yeah, helmet cell. What are helmet cells also? Very good. I am liking how this. And somebody actually had told iron deficiency anemia. Perfect. I like how you're thinking. So iron deficiency anemia, helmet cell. What are helmet cells also called? Anybody?
Hinge bodies? No.
No. Heinz bodies to दूसरे होते हैं. Heinz bodies are the ones that I told earlier. Heinz bodies, when your hemoglobin is getting agglutinated because of the oxidant cells, no, usko Heinz body bolte. And when they go to spleen, and the spleen macrophages will eat that agglutinated
Ma'am, can it be spirocytes?
Spirocytes. Okay, we'll see why it is not spirocytes also. Very good. We're getting all sorts of answers. So, okay, fine. We'll approach how, why, what, and all. So, iron deficiency anemia. एक और भी बोल दो यार. There is clumping also, no? You can see two RBCs on one another. Why can't it not be? Splenomegaly also occurs in this case. So splenomegaly essentially will occur in your extravascular hemolysis, right? Extravascular hemolysis are all these things. We'll pick up all these in detail later. So, okay. So whoever told iron deficiency anemia, right? Schistocytes, helmet cells, right. So this is actually a schistocyte. So we wanted, right. We will discuss iron deficiency also. And somebody mentioned sickle cell. So we'll just go through why and what of all this. So the person who told me iron deficiency anemia, I'm going to assume is thinking कि central pallor ज़्यादा है, microcytes दिख रहे हैं, so it is iron deficiency anemia. Excellent pickup. I will give credit to you for that. But let me ask you, hemolytic anemia, can we not expect iron deficiency? Can we or can we not? use the similar logic I told for folate deficiency. Yeah, right? So of course, right. So this could be a hemolytic anemia with iron deficiency anemia, right? Right. Good pickup, Roshan. Good pickup. So the other things were, why are these not sickle cells? Why are these not spirocytes? And why are these what we've called as schistocytes, right? So let's just look at these. I just wanted to show this because we were discussing about no, where is basophilic stippling यहाँ पे? I can't see anything. Can you? So this is why this is actually a spirocyte, right? So what happens in spirocyte? Why are we actually having spirocytic anemia? Anybody? What is the usual shape of an RBC? What is the usual shape of the RBC? Usually RBC will be biconcave, right? Excellent, Zainab. So usually biconcave hota hai. And what happens in spirocytosis? Biconcave is a perfect answer, right? So what happens in spirocytosis? Anybody? Right, they become spherical. तो round हो जाते हैं. Anybody can tell me peripheral sphere में क्या बोलते हैं उसको? What increases MCV, MCH? You know, usually ऐसी होती है RBC. This is how the RBC should be, biconcave, right? RBCs have become like this, right? These are what are your classic spirocytes. RBCs become like this, right? Spectral ankyrin will go into all that. Right. So are these cells round? वैसे दिख रहे हैं क्या आपको? To consider it as a spirocyte, the marked cells? No, no, no. Another person asked, is it sickle cell? Right. So just pick up sickle cells here for me. Can you see sickle cells here? Can you pick up sickle cells? I understand. You know, usually in clinically it's very different to differentiate a sickle cell from from a schistocyte, but usually sickle cell ka surface area will be very less. Okay, so these are the peripheral smear things that I wanted to show. Okay, and let's just go through two more peripheral smears where everybody gets confused. Okay, so in this peripheral smear, I'm seeing clumping, and in this peripheral smear, I'm seeing classic Rolex formation. What is this? Where do you see both? You know, this is a very important thing to differentiate, which not a lot of people tell you, or not, you know, you don't really understand initially. Agar mujhe peripheral smear mein clumping, I see clumping in one, I see Rolex in one. What am I thinking? In what direction am I thinking? So see, usually clumping, right? Right. So there are a lot of reasons for clumping, and and Roshan is perfectly pointing out, you know, whenever there's an increased ESR, you know, you can have, and classically autoimmune hemolytic anemia, we have read now ki autoimmune hemolytic anemia is another case where you'll have clumping of RBCs on your peripheral smear, right? Perfect. Right. And Rolex formation. If I see Rolex formation, what am I thinking? If I see your Rolex formation, what am I thinking? This is actually not the topic of discussion, but I just wanted to tell you, multiple myeloma, right? Increased viscosity of blood. Kahin pe bhi ho, you can have Rolex formation. Classic example will be a multiple myeloma. The thing that put these things together is you need to be able to differentiate, yeah, even leukemia, right? Basically, jahan pe bhi, wherever there is increased, you can have Rolex formation. You know, clumping is indicative of EHA, Rolex formation is indicative of multiple myeloma. It's not a hard and fast rule. I just want to tell you how to pick up the difference, how a clumping will look on a peripheral smear. Yes, there is a relationship between red cell mass and ESR. Usually, when we have ESR now, we expect the red cell mass to get increased and hence the clumping. Okay. So clumping of RBCs will look like this on a peripheral smear, and Rolex formation will look like this on a peripheral smear. Please don't get confused. Okay. So we'll just come back to hemolytic anemia, and we were discussing about hemolytic anemia can be intravascular as well as extravascular. If you have intravascular, which means that the blood cells are being broken down within the blood vessels, and because the blood vessels are being broken down, you know, the breakdown products will bind to haptoglobulin, and hence you will have a decreased haptoglobulin. And because, right, direct bilirubin, वो तो हर hemolytic anemia में होगा, okay? So then schistocytes will be seen on peripheral smear because of the breakdown of RBCs. And if you have extravascular, which means that the RBCs are being broken down apart from the blood vessel, which is ideally the spleen, you'll have a splenomegaly, okay? So we've seen the peripheral smear images. We have seen the approach. How do you kind of think it is a hemolytic anemia? And this is a very brief, can multiple sclerosis cause Rolex formation? Why do you want to ask that question? Why multiple sclerosis can cause Rolex formation? Any explanation? Okay, we'll pick it up. So hereditary spherocytosis. What is MS? Where is MS? I'm sorry, where did I mention MS? Multiple sclerosis is MS, no? Or have I written it as, yeah, that's it. So, okay, fine. So these are just the, a brief brief introduction into what are this everything. So in hereditary spherocytosis, we expect a membrane protein defect. A classical thing will be, don't neglect the hereditary pattern, This is autosomal dominant. So if they're telling you that in every age, a child, every generation, say if they're giving you a history that his father had splenectomy or his grandmother had a splenectomy, that is something that they're pointing towards, saying that almost every generation is being affected. So you can think about hereditary spherocytosis. Sometimes the inheritance pattern can also give away the diagnosis, right? So membrane proteins, spectrin and ankyrin. And what are the other things? You'll have splenomegaly, you can have pigmented gallstones, because, yeah, we'll discuss all those in detail in the subsequent topics. This is just a brief introduction of how to approach. Okay, Roshan? I just got a half an hour class and I'm squeezing in whatever I can. Okay. So splenomegaly, pigmented gallstones, and you will usually have a family history of splenectomy, right? So how do you see? There will be a normal to decreased MCV. This is what I was trying to tell you, that usually biconcave cells will be like this and spherocytes will be like this. Because of this, you can expect a decrease in mean corpuscular volume, because the same RBC is occupying more space, more volume. Okay, there will be an increased osmotic fragility test, and the investigation of choice. A lot of people miss this. The investigation of choice is EMA binding. So what happens in EMA binding is that we are introducing, it's impossible in, yeah, exactly. So what is EMA binding? So EMA binding, this dye, which is a radioactive dye, it will go and bind the spectrin and ankyrin. And because these RBCs do not have these molecules, they give you that cycle instead of directly saying there's decreased glutathione. So be prepared like that as well. Okay. So these people will usually have hemoglobinuria after oxidant stress. I told you, we were discussing, right? Malaria treatment, yeah, flava beans or sulfa drugs. And on peripheral smear, you'll see Heinz bodies with bite cells, right? And you'll have a decreased G6PD activity in this case. Then we have pyruvate kinase deficiency, which is an autosomal recessive, right? And in this, what happens? Pyruvate kinase is defective, so you'll have a decreased ATP, and this will cause extravascular hemolysis. On peripheral smear, you'll see Burr cells. So I'll just quickly let's just do a couple of questions and end the session. I understand we haven't discussed sickle cell and autoimmune. We'll do it some other time. It's getting too late. So let's just try and attempt these questions, okay? And I want active participation, right? 5, you're just thinking everything is anemia, but USMLEs, they don't ask you like that. So let's just read the first question together, right? 1-year-old African American, okay, is got the complaints of severe swelling and tenderness of hands and feet, okay? So we have swelling of hands as well as feet. Got it. And they don't know why this swelling has happened, and there is no sick contact as well. Family, okay, okay, Ali Hassan says it is serum albumin. I like how this is going. Good. Thank you, Omid. Okay, so 2 people think it's serum albumin and 1 person thinks it is serum haptoglobulin. Okay, so why not LV systolic dysfunction? My heart is not functioning properly. I have pedal edema. I have edema all over the face. Why can't it not be LV systolic dysfunction? Anybody? Why not LV systolic function? My heart is not functioning properly. I am having edema. Why can't it not be an option in this? Yes, Dr. USMLE, you want to go? Age. No, don't see. These other things. I have serum complement deficiency. So we'll have facial swelling, hand swelling, leg swelling. Why can't it not be serum complement deficiency? I'm just telling you how you should approach the case, because everything somehow seems to fit in. Somebody told serum albumin. They're thinking, there is protein loss, so there is decreased osmotic pressure, and there is edema all over the body. That is also a good thought process. I appreciate you're thinking in a different way, just because we're discussing anemias, you've not told it's serum haptoglobulin. It's good. So why not the rest when you can expect edema in everywhere else? Okay, so I'll tell you complement binding problem of what? That will be pain in your extremities as well as swelling, right? Essentially fingers, right? Pain and swelling. And I told you, always have an eye for family history, okay? So when they're telling you family history of a pneumococcal sepsis, so what do I want to think about pneumococcal sepsis? Yeah, it is correct, but you haven't explained how it is correct. So I'm just going ahead and, telling you. Okay, Rochelle, tell me. You told me, what is pneumococcal sepsis pointing here? What is the significance of his elder brother having pneumococcal sepsis? Why? What is that significance of that point there? How is it supporting your serum haptoglobulin diagnosis? Yeah, of that, how? I mean, yes, family history is there, but how is it helping you in diagnosis? So, usually, when you do not have a spleen, you expect infections from encapsulated organs, right? So they didn't know it's not complement deficiency. There is no spleen, Baba. There is no. You expect infections from an encapsulated organisms, right? We read Streptococcus pneumonia is an encapsulated organism. Pneumococcus is a encapsulated organism. So what that line is, instead of directly telling that there is a history of autosplenectomy in the elder brother, they are telling you that there is pneumococcal sepsis. What does pneumococcal sepsis mean? Pneumococcus should have normally been removed by the spleen because this child doesn't have spleen, which means that they are indirectly telling you there is autosplenectomy in his elder brother. How you see, everything will not be given directly. This is how you derange what they're trying to tell. That line was kind of giving away that there is an autosplenectomy in his elder brother, and that is why he died of pneumococcal sepsis. Okay, so dactylitis put with autosplenectomy will give you what is called as sickle cell anemia. And in sickle cell anemia, thank you. So let's just think about LV system. So wait, a couple of people told me serum albumin. So whoever told me that they were thinking, just type in the chat box. This is the last discussion we're doing for today. If there is serum albumin deficiency, where in body do you see edema first?
Legs.
No, it is usually serum the edema of your fingers and legs, right? Right. So that is why edema.